we all mute throughout unless you're presenting so we don't get any background noise. Captions are also available today. So if you want to view captions, click on the 3 red dots at the top right-hand side of your screen. If you select languages, turn on captions, and then they will display along the bottom of the screen for you. So we've got an action-packed hour ahead of us with lots of great speakers, and we'll be using the chat function today for any questions. We've got a short amount of time at the end of the webinar with our panel to answer a handful, but we likely won't get through all of them. But what we will do is commit to gathering up all those questions in the chat and forming a bit of an FAQ document post-webinar and circulating that with the link to the recording. So that's all the housekeeping bits done. For those of you that aren't familiar or don't know me or Sport England, I'm Susie Gittis, one of the national partnerships leads in the health team at Sport England. And we are an arm's length body of government responsible for growing and developing grassroots sports and ultimately helping people stay active across England. And our strategy called Uniting the Movement has a particular focus on those of greatest need in order to lead an active life, because sadly there are lots of inequalities to being active, such as where you live, your background, even your gender, and in fact your physical and mental health. And that's backed up by our national physical activity survey, Active Lives, and it tells us that people with a diagnosed mental health condition are far more likely to lead an inactive life, and yet they have possibly the most to gain from being moving more. And that's why really we're particularly interested around working with mental health services to support more people to help manage their mental health through movement. We've got some great speakers for you today on the webinar. We're joined by Eleanor and Andrew from Transformation Partners in Health and Care, and they're going to tell us a bit more about the importance of physical activity within services. And also Andrew will take you through some of the insight and recommendations within the reports. We'll then hear from Judy and Patrick, who are going to share some good practice case studies, and I'll talk briefly about some next steps, and we'll round off with the Q&A. So that's what you can expect from us from the next hour. So without further ado, I will pass on to Eleanor, who's going to kick us off.
Thank you, Susie. Good morning, everyone. My name is Eleanor Johnston, and I'm a Senior Programme Manager for Talking Therapies within Transformation Partners in Health and Care. And we are an organisation who have worked very closely with Sport England on this work. So just by way of background, for those who aren't familiar, NHS Talking Therapy services provide support for adults with common mental health conditions, and referrals are normally made from a GP or via self-referral. There are 155 talking therapy services in England which offer support for adults, and these services were also known in the past as IAPT, or Improving Access to Psychological Therapies. In 2021 to 2022, 1.24 million people accessed the services provided by Talking Therapies, or what was at the time IAPT. So Talking Therapies are different treatments which are offered for mental and emotional problems, and can treat a number of conditions including depression and anxiety, phobias, obsessive compulsive disorder, post-traumatic stress disorder, and other conditions. The types of therapy varies across different services, but broadly that offer includes cognitive behavioural therapy, guided self-help, counselling, behavioural activation, and other forms of therapy. Next slide, please. Sorry, I've been muted. Thank you. So why is this work important? Some of the priorities for Talking Therapy services include the service expansion and the focus on long-term conditions, as well as improving the quality of services and experiences of people who are accessing Talking Therapy services. We know that there is a huge evidence base around the benefits of physical activity on mental health. However, physical activity is not routinely a part of treatment through Talking Therapy services. In addition, there is a high demand which has been exacerbated by the pandemic and cost of living crisis These have both had a huge issue on the nation's mental health, and it's important that services now more than ever are able to explore innovative ways that support patients to recover and self-manage their mental health. And finally, the role of services is incredibly important. Services are uniquely positioned to support people around overcoming barriers such as motivation through the use of psychological techniques in traditional practice. I will now pass you to Andrew, who will be speaking through the insights and recommendations of the report.
Thanks very much, Eleanor. My name's Andrew Granville. Along with Eleanor, I work in Transformation Partners in Health and Care, and I was part of the team that conducted the research that led to this report. So I'll be speaking about what we found and hopefully bringing to life some of those headline figures and recommendations, maybe even whetting your appetite to take a look. So it was striking that everyone we spoke to pretty much thinks that physical activity is really important in improving outcomes for people with common mental health conditions. And we were talking about their mental health outcomes, not even their physical outcomes. But at the same time, there's a widespread sense that not as much is being done as people would like to promote that. So that led us to some clear recommendations, which we'll come to at the end. How did we come to these conclusions? We spoke to service users of NHS talking therapy services, 86 of them. They were broadly representative of the wider talking therapy service user base. We spoke only to adults. It was a slightly more active survey sample than perhaps across the national picture. More than 200 talking therapy staff, 32 physical activity providers, and a handful of experts from Commissioners, NHS England, and the Department for Health and Social Care. Thanks, Susie. So what can we learn from what the service users told us? Service users shared the main barriers that they experience in being physically active. Some of them, as you can see, motivation and time, you might expect anybody, any group of people to share. But there were three in particular that I want to draw out, the ones in the red boxes. Long-term conditions and mental health conditions are particularly large barriers for people. And I want to share a few quotes from service users to illustrate and bring that to life. So poor mental health impacts on physical activity in specific ways. You can see in the bottom left quote, a service user wrote, "I'm unfit because I really struggle to overcome all the mental health issues like anxiety, stress, depression, and low self-esteem that have to be tackled before I end up in a location and outfit ready to exercise." So this really reflects how mental health can increase the effort that's required to get to a place where you can be active, especially if it's in a shared place with others. Another service user wrote, "Mood and motivation are a barrier. Sometimes I feel so down that I purposefully avoid gym sessions and don't leave the house." So this is about more than just motivation. It reflects the greater psychological barriers that people with mental health problems have to overcome before they can participate in some of these activities. Long-term conditions also present specific challenges. Not all activities are possible for all people. There's often extra uncertainty and anxiety, both for service users and staff. And fatigue is also likely to affect people with long-term conditions and mental health problems. And these challenges are all the more impressive when you consider that despite these barriers, physical activity was a real priority for service users we spoke to. 90% of them are active for 30 minutes a week or more, 40%, 150 minutes or more, and more than half would like to do more of at least one activity.
Excuse me, sorry to interrupt, but there seems to be like a different link and there's like 100 people waiting in the other like meeting or anything like that. Is there anything to do there that we can message over? Because I'm unsure. I'm just getting a lot of messages and unable to hear you at the minute.
Thanks, Martin. That's really helpful to hear. I suspect there's somebody who can pick that up.
Hi, sorry about that. Eleanor, would you be able to send the link, please?
I've sent the link, thanks.
Great, thank you. Hopefully we've got that sorted.
Thanks very much.
Thanks for letting us know.
Excellent. So I'll carry on. And as Susie said, this webinar is being recorded so people can pick up anything that they've missed later on. So Susie, next slide, please. So long-term conditions present specific challenges for being active as well. Arthritis, injuries, chronic pain, all of these are going to make it hard for people to be active, especially when they're combined with depression, anxiety, or other mental health problems. And this interdisciplinary, intersectional aspect of mental health makes it particularly challenging for practitioners. Talking therapy services are focused on mental health. That's their expertise. But a sizable minority of service users are experiencing multiple mental health and physical long-term conditions, and both of them together. And indeed, that's only the ones who listed them as a barrier to being physically active. Altogether, more than half of our respondents had a physical long-term condition. Next slide, please. So we asked people what kinds of activity were most appealing for them, and there was a real variety. Group activities, or activities that can be done in groups, were often the most popular, and especially walking. You can see down on the bottom with that big green bar. Walking is really accessible, it's really flexible, it can be group or individual, it can be longer or shorter, faster or slower. And you don't need expensive kit or memberships to be able to do it. But also swimming, cycling, exercise classes were all popular. And it's worth adding that online support was also really appreciated. Only a third of people wanted pure in-person support. I think I was muted. Being in the comfort of your living room is much safer, can be much safer than being physically in front of others, which can feel quite exposing. Next slide, please. So what helped people become more active? The experience of doing things with others is really important. That sense of a friendly face, not being on your own, but also the actual personal experience of the benefits of activity. Again, this is perhaps not unique to talking therapy service users. And having a specific exercise to do was really helpful, rather than a more generic encouragement to be active. So as an example of what to avoid, one person wrote, "Support is very limited. They just suggest doing activity will improve my mental health." And service users wanted support not just from community physical activity providers. Almost 2/3 said they would like to have more support to be active from NHS services, including mental health services. And a similar number say they don't receive any support at the moment. So as an example of how this can be relevant within a psychological setting, a service user wrote, "In my NHS talking therapy sessions, the therapist was kind and gentle, encouraging physical activity, celebrating when I had cycled and pointing out the positive effect it had on my mood." Next slide. So what are talking therapy services doing to support physical activity? So we asked staff the same questions about the challenges they experience, and a lot of these prefigure some of the recommendations that we're making. So in terms of service user barriers, one clinician wrote, "I work with people with long-term conditions, and that can be a barrier as they can be very limited in what they can do." And we'll say a little bit more about that later on. But in particular, those 3 red boxes I wanted to draw out. So in terms of awareness of services and partnerships, only half of staff are aware of the local activity provision there is, and only 1/3 of them are working with external partners to support physical activity. One clinician wrote, "We cover a large area, so sometimes it's difficult to know the local offerings to signpost people to. We would like to have links with key providers and make referrals." Another said, "I'm limited to signposting clients to support services, but I'm not aware of how many of them there are or how they work. It would be good to form community partnerships with services that might support physical activity." Another challenge is a lack of session time and frequency, which really translates into a lack of priority. So some quotes to bring this out. "Change must come from the top. NHS talking therapy services are very manual and guideline based, but physical activity isn't integrated into that and isn't well fleshed out in the guides. If this is not updated, many will not implement physical activity." Another clinician wrote, "There isn't a designated intervention or opportunity to talk solely about physical activity. It's always seen as an add-on rather than an important entity in itself." And a third wrote, in not a lot of time in terms of session numbers. So making time to discuss physical activity tends to fall to the bottom of the priority list, unless it's a specific goal the clients themselves say they want to work on. And finally, a lack of confidence or knowledge about how to support staff into physical activity. A lot of staff describe this too. One wrote, "We often have workbooks that differ for different issues. I don't think we have one that focuses on physical activity. It's not something we really discuss in supervision, professional development, or training. I can't think of that many signposting options for it." And you can see the quote on the left, "Protocols and training may be helpful here in making it a regular part of treatment." There's also some anecdotal data that suggests that talking therapy staff who are themselves more active do more of this than others. So again, next slide. When we look at the barriers, it's worth remembering that these are in a context in which talking therapy staff think this is important, and in which clinicians are pioneering and developing exciting new approaches, which we'll hear more about later. And the quote on the right, "Physical activity is a key element in helping people sustain good mental health." So there's a real commitment to finding ways to support this. And despite all these challenges, more than half of clinicians think that there's at least some flexibility in their services to be able to support physical activity. Next slide. So lastly, what perspective did physical activity providers have? So our work was initially quite NHS focused, but there were some really useful and distinctive insights that the physical activity sector had to offer. We expected to see low engagement, and there is correspondingly. So down at the bottom, you can see about a quarter, 27% on that blue bar on the bottom, of physical activity providers are currently working with talking therapy services. And only about a third, or 38%, have specific plans to do that. But there is high interest. You can see those big bars, they're not currently. So nearly half would like to, and nearly half have a high level ambition to. Next slide. So we asked physical activity providers what some of their key insights were, and we got some really useful points here, although only 7 responded to this. So it suggests that while there are some really important insights, they may not be distributed all the way across the physical activity sector. Again, there's a point here about expertise not being widely distributed geographically as across the NHS. So you can see here there's a point about exclusion, that talking therapy service users perhaps have an increased risk of isolation, may struggle with internet access, may be difficult to contact in traditional ways, and may struggle with finances. Anxiety, quieter classes being a really helpful adjustment there. A need for extra support from their referrers. The importance of fitting activities to their ability levels, and creating a positive environment, for example, by using non-mental health slogans to avoid othering them within the physical activity setting. And lastly, finding ways to bridge the gap with NHS services. So this is really important. And next slide, that importance of bridging the gap between the NHS and physical activity sectors. Some of the most exciting examples we found involved strengthening the connectivity and relationships between physical activity providers and the health system. So that's supporting talking therapy services to identify appropriate providers for a service user, developing the shared understanding of what activities and ability levels are suitable for people with different conditions to refer with confidence, and creating seamless pathways so that once the referral is made, nothing gets in the way of the service user accessing that provision. And this is about more than just signposting and leaflets. It's about specific nudges with clinically informed encouragement about physical activity. It's about peer support. It's about showing therapists how they can help by attending initial sessions, by enabling tasters of activity within the therapy. And we found that active partnerships were really well placed to provide some of that bridging function. Sport England is working really closely with them. There's a huge opportunity to advise and connect across these two sectors. So these active partnerships are independent. They work collaboratively with local stakeholders to grow this movement for movement. And where active partnerships were involved, we often found there was a stronger platform for ensuring that the right provision was available and that it was meaningfully accessible, bearing in mind everything I've just been describing, to service users and to referrers. Next slide, please. So what practical steps can talking therapy services take to make a difference here? So we uncovered 5 approaches, and we'll hear a bit more in a minute about some of these in more detail. So education, videos, apps, giving information and encouragement. And that's mostly for service users, but it's also for staff and giving them training in long-term conditions perspectives. Delivering physical activity sessions directly by the talking therapy services, making it very accessible, but requiring extra resource perhaps. Delivering physical activity within the therapy, so adjusting the modality to be walking and talking, for example. Recruiting specialists who can support with referrals, pathways, signposting, and co-locating within leisure facilities, obviously increasing communication and reducing the effort of making referrals. And it's worth saying that while these are all really promising and exciting, they're all still pilots or near pilots. And there's not as much evidence as we'd like on exactly what their efficacy is. Again, this is going to feed into our recommendations. Next slide, please. So there's lots to go after in improving the situation. And there's lots of enthusiasm and interest. And some of these recommendations, they speak to different levels and different key players. So first, this needs to be a priority for talking therapy services that gets enough resource and time. As we heard, talking therapies are quite manual based. Guidance and incentives sit with NHS England. So we recommend that they should align closer, the manual should align closer with the new NICE depression guidelines, that there should be protocols on how to embed physical activity into core talking therapies conversations, and appropriate financial incentives to make this a priority for talking therapy services. And measurement is really important here, both to incentivize services to incorporate it and to build the evidence base for the efficacy. Secondly, staff need to have more confidence, need to be able to have more confidence in supporting service users to be physically active. And it is better to be physically active. There's a really useful consensus statement in a report from the Faculty of Sport and Exercise Medicine, which was co-produced with Sport England, the Office for Health Improvement and Disparities, and the Royal College for GPs, saying that it is safer for people with long-term conditions to be physically active. And that message isn't universally known or understood. So this looks like training, the training offer for staff to understand the value of physical activity and what kinds of physical activity there are, how to support service users into that, and awareness of the real limitations and what limitations may not be as real or as fixed as people think at first. And it's also the awareness of what opportunities and pathways there are available. So who's involved in this? There's a large part again for NHS England, especially with their soon to be incorporated functions of Health Education England, and CPD, continuous professional development, is a really important tool for making some of these things happen. Our third recommendation was about collaboration. Public services are obviously very stretched, and it's challenging to stay on top of each other's work and agendas. So specifically, the active partnership networks we think are a really helpful way to support this collaboration, maintaining and sharing databases of what physical activity services there are. Social prescribing, where people can be referred or prescribed to social and physical activities by NHS services, are a great approach to support more of this. And there's a key opportunity for physical activity champions, which we'd love to be explored and developed further within talking therapy services. So who are the organisations and people best placed to support this? Local authorities and sport development leads are going to play a key role here, as well as organisations like Sport England and Active Partnerships, bridging the gap and reaching out to both sides. And finally, there's so much good work that's happening, but a lot of it is held locally. There are not the forums to disseminate and develop and roll out some of those models more widely. So we're recommending a joint plan across physical activity and mental health partners to promote best practice and emerging work. In the short term, that might look like a positive practice guide, an implementation toolkit with case studies like the ones we're about to hear. It might also mean sharing the learning from the national green social prescribing pilot sites, which are going to report about how to scale up green social prescribing and nature-based activities. Over the longer term, it might involve setting up communities of practice for talking therapy services to support knowledge sharing, the disseminating and the developing of models. So those are our recommendations. Thank you very much for the time. I'm going to hand over now to Judy, who's going to start to describe some of the work in Camden and Islington.
Thank you so much, Andrew, for that really useful summary of the various recommendations. I've got 5 minutes to talk to you quite briefly about some of the work we've been doing in the talking therapy services in Camden and Islington and Buckinghamshire. So we have a partnership with Bucks, and we were keen to look at developing and implementing a range of possibilities for how we might incorporate physical activity more into our talking therapies services. So the first thing I want to do is just quickly say what the various interventions we're looking at are. One is that we adapted a CBT for depression group to integrate an element of physical activity into each of the sessions. So we've been doing that across Camden, Islington and Bucks. The other thing is focus more on people with long-term physical health problems, so long-term conditions. And we've developed a series of workshops for people with long-term conditions who are receiving treatment in our IAP services that focuses particularly on the barriers and challenges for them in getting more physically active. We've also linked up with a digital app company to have access to people using our services to a particular some modules within a digital self-help app, which are again focused on helping people to move more and be more physically active generally. More recently, we've been training up a few staff to deliver what we call walk and talk sessions. So that's again integrating an element of brisk walking into our program of one-to-one sessions for depression. So that's still relatively new, but that's something we're looking at doing. And then in Buckinghamshire, they've been working together with a local series of walking groups called Simply Walk to really try and sort of smooth out the pathway between the talking therapy service and access to local walking groups. So there's a few key things I wanted to highlight really around the work we've been doing and the development of these piloting these interventions. One is that we've built in an element of evaluation. Andrew was talking about the importance of developing the evidence base for this sort of work. So we've are working with colleagues at UCL to do to get as much data that we can on the outcomes. We are particularly interested in the mental health outcomes and whether the interventions or adjuncts to interventions that offer more opportunities for physical activity will improve our mental health outcomes. We're also interested to see whether we can measure whether people are actually doing more physical activity, which is quite complicated as well. But we want to also get some more qualitative feedback from people who've used these services to see, how they felt in actually using and getting involved in these activities. We've involved users of our services all the way through the program, and particularly in helping to develop the interventions and how we present them to people, how we talk about them, how we describe them, how we kind of market them, if you like, within our services. There's a lot of effort has gone into getting involved in sort of training, upskilling our Talking Therapies workforces. And this is a very important area which Andrew sort of highlighted. And the way we've done it is a real mixture of some more formal sort of training events for staff, but also really importantly, you know, frequent mentioning of things in team meetings, frequent sort of offer of consultation slots for people to come and talk about how they might, whether their clients are suitable for one or other of these interventions, and just really trying to get the workforce thinking a little bit more about how you have conversations about physical activity. Our emphasis, I should say, has been much less on doing loads of exercise and sport. It's really much more about, you know, moving more, getting more active at a level that feels doable for the individual. And I think we've had to sort of fight against the sort of fear that some people have that this is about making them all run marathons or, you know, go jogging or do long bike rides. So say walking is really important as well, and that's something that feels probably more accessible to more people. Collaboration with local partners, I think, is really essential. In the Buckinghamshire service, they've got an active partnership called LEAP that has been very involved, particularly at the beginning of the project, and has, I think, been an important source of local knowledge and local information about physical activity opportunities. And again, I think Andrew highlighted the importance of this. In Camden, Islington, it's been more links with a local authority that we are really trying to sort of foster and develop, because there are a lot of things going on locally which talking therapy services need to know about and be able to link in with. The last thing I wanted to say is about what next. So the project is continuing. We are hoping to have a sort of more formal element of the evaluation done by the end of the year. We feel that we've learned an awful lot trying to do this work. Some of the challenges, some of the barriers, and the things that have been most effective in overcoming those. And we are keen to contribute to developing a toolkit where we'll give more information about the details of some of the interventions that we've developed. Very happy to share all our materials, but also the learning and how we've kind of shifted things and adapted them over time to really engage with people as well as we can for this work. And I gather there is going to be another webinar at some point in the summer where we might be able to give a bit more information about the detail of what we have done locally. But if anybody's interested, I would be very happy to be contacted directly if that would be useful. So thank you very much. I'm going to hand over now to Patrick, who's going to talk to you about the work that's been done by the Living Well Consortium.
Super great, thank you. I suppose I'll start by introducing myself. My name is Patrick, and the surname, as you can read there, is Kwesiga. I always ask people to pronounce that, but I will help you. It is Kwesiga, so if you've tried it right there, you've got it. Patrick Kwesiga, I'm the Executive Clinical Director of the Living Well Consortium. I suppose I want to start from walking the talk. So we have been here for more than 30 minutes. Let's do a bit of about 15-second exercise. We cannot talk without doing. So it's going to be, as you start there, it's going to be chair-based exercise. So you're going to stamp your left foot down, boop, and then right, boop, left again, boop, right again, boop. Then you lift your left hand up. I can't see the hands up for those of you that are on video. Yes. And then down, and then right up, and then right down, then left up, then left down, right up, right down. There we go. Okay. So then I'm going to do a bit of my screen setup here. I've got a bit of visual adjustment, so you will bear with me. All right, so there we are. There we are. Okay. And I've got now no more than 4 1.5 minutes. I will time myself here to make sure that I don't eat into time. Okay, so I'm going to talk about a case study of our Living Well Consortium Walking Therapies service. Of course, we are based in Birmingham in the Midlands, and we provide NHS talking therapies for BISO system, that is Birmingham and Solihull. And so we set our service based on the talking therapies, then IOPT service, and we deliver this. So the intervention is individual and group sessions, and of course with personal trainer, and or chair-based activities using psychological well-being practitioners. And these take place in open places like parks or large community venues where we go and meet with our patients or clients. And we partner with a few providers or organizations or stakeholders like Run of a Kind, and this is part of the Couch to 5K sessions that we deliver. And sorry, there's a bit of, I'm going to do something here. The messages are obscuring. Excuse me, the messages are obscuring my presentation here, so I'll do something different. Okay, so we also deliver collaborative work with a number of organizations like schools, local churches, faith groups, and in care homes, people that are in care homes or residentials. So we do go there and deliver these activities. And of course, the outcome and impact, we've had various feedbacks from our patients, clients, whatever we may call them, or customers. And this is done through patient experience questionnaires. For those of you that are in talking therapies, you know this, where you capture feedback from clients. And we have also noticed that there is high recovery rate of 60% plus through walking therapy service as opposed to the other models of talking therapy. And of course, the national expectation, as you know, is 50%. But as I said, for talking therapies, it is in the range of 60% plus. So we are also developing, as part of the outcome or impact of this. So we are developing new ideas of getting higher attendance, and of course through more collaborative work, because it is some kind of a novel service. It's new in talking therapies, or IOPT as it was, to deliver this kind of service. So uptake may not necessarily be as great. People may not quite understand it, but of course, for those that have taken it and understood it, sorry. Yeah, for those that have understood it, they do enjoy it. And we're developing, of course, more ideas around what we can integrate in talking therapies. So things like mindfulness, of course, CBT, counseling, all these as we work and support people. Including trying to develop more the couch to 5K. So in partnership with the run of a kind and coach 2 or 5K sessions. So these are some of the things that we are doing. I will finish with a personal experience myself as a kind of a disclosure. During the pandemic, from around March 2020, I personally facilitated online remote virtual exercises, and we were having about 30 to 50 families, so those about times around 4 or 5. So we were having around 154 individuals, and we all scrubbed through the pandemic with our heads high because of this. And now it continues even post-pandemic. It may not be as in great numbers as it was during the pandemic, but we do continue to, I do continue to facilitate this, what we call dance movement fitness and feel good therapy to support communities across the divide. And I can say it has improved my well-being, sustained my well-being, and I always look to it, as indeed this is the same feedback that come from the other participants. And that's what I wanted to share in my allotted 5 minutes that I've used for 4 minutes and 55 seconds. Thank you.
Thank you, Patrick. Loved the exercises there and the personal reflections. I'm just going to talk to you a little bit now about next steps. Thank you to all our speakers, Eleanor, Andrew, Judy and Patrick today. Appreciate there's a lot of information to take in there, and it was a little bit of a whistle-stop tour. But there's far more detail in the full reports and the assets that are available. So there's more case studies, there's an at-a-glance summary as well, and a really visual breakdown of some of the insights and recommendations. So really encourage everyone to access that on the Transformation Partners in Health and Care website. My colleague Hannah is just going to pop that link in the chat. And we really hope that the insight and recommendations have been useful. And if you're thinking about exploring this area, that you can consider some of the things, small or big, that help you to explore this locally with partners and use as a bit of a conversation starter. We're going to be continuing to promote the recommendations and insights. And we're also looking to take some of the recommendations further. Particularly around some of the national levers. So looking at guidance, training, and some of the sort of manual development opportunities with the national team at NHSE. And as Judy mentioned in her section, one of the things we'll be doing is starting to create some more webinar content. And the first of these we're hoping to be in June time, where we'll do a bit more of a deep dive into the Camden and Islington and Buckinghamshire case study. And that will be sharing a bit of a warts and all. So how did they go about setting it up? What are the challenges they faced along the way? How did they work around them? And we'll also start to share some of that emerging clinical outcome data that we know is really important and valuable to make the business case for doing this. And so we will share information on that in due course. So we hope some of you can join in and tune into that too. As we mentioned earlier, the chat function, you can pop questions in. And we're going to move across to Hannah now, who's going to chair a bit of a Q&A to finish us up with the panel. And I'll stop sharing my screen so I can see everyone's faces.
Lovely, thank you, Susie. Yeah, so it's been really great to see the chat function being used so much during this webinar, and all the connections that are being made as well has been really incredible to see. I have put a few links to things such as the Active Partnership Interactive Map. So if you're not sure who your local active partnership is, you can click on that if you just scroll back up through the comments. And as Susie said, I've just put the full report to the link in the chat as well. So please do go on and have a look at that. I was trying to keep a little bit of a check on what was going on in the chat. I did see a couple of questions that came through. which I will pose to our panel. But if anybody else has a question, if they want to put their hand up, please feel free. The first one I saw was from Temi in the chat, and her comment was around, we are aware of long waits into treatment. How might physical activity prescription be used as a while you wait kind of offer? So I don't know if Eleanor or Andrew or anyone, the speakers, want to answer that one for us.
So I can share briefly that this is a really interesting point, because at any moment there are quite a lot of people waiting to start accessing talking therapy services, for whom physical activity is no less important than people who are currently accessing them. And it did come up in some of our focus groups, especially with active partnerships colleagues, who many of whom were kind of thinking and working about this quite explicitly. And we didn't come up with any very easy answers, I'm sorry to say. I think it can sometimes be tricky, but I think those are the kinds of conversations that that are really important to start having with talking therapy services, about what kind of contact it's appropriate and possible to have with people who are on waiting lists, and how to support them, so that then it's not all changing all at once when you start the service.
Sorry, can I add to my query? Because while I was talking about people on the waiting list, it could be people waiting who are waiting in treatment as well after their first assessment, so or first treatment. So it's equal to not just people who are just joining or about to join treatment from the NHS talking therapy services, but also for those people who are waiting for the second treatment, which often done not, as we know from a number of our services. And I'm talking from a North Central London perspective here. It could be quite long in terms of the waits. And then there is the issue about engagement and dropouts, and all the other kind of stuff that goes with that. So the question is much more rounded than simply about those people, new patients coming into the service.
So Judy and Patrick have both got your hands up. Did you want to come back in on that question at all, Judy?
Yeah, I mean, I definitely think that we need to have more information more easily available for people at all points, as you're saying, Temi, of the pathway, for about how they can get support around this area. There obviously are some people who part of their presentation is their difficulty in motivating themselves, and so they might be quite unlikely to pick some of this up without you know, a lot of support from the service. But there definitely are people who would be interested, and we need to find kind of creative ways of making sure that information is disseminated in a way which is easily accessible and picked up by people. 100%. I mean, one of the things that we found locally is that sometimes just relying on the clinicians to talk to people about this wasn't necessarily the best thing to do. Sometimes actually sending people who are waiting for their first appointment or starting treatment information directly via email or text or a webinar that they look at is more effective, and then people can make decisions themselves about what they want to access. So I think that's we just need to think a little bit more broadly about how we share this local information with people.
I'm sorry, I'm just coming back in again, because I'm just thinking of Haringey, where we've got a lot of working groups. Some of them are run by, for example, Mind. Mind is an organization that's national and local, and perhaps that link between our NHS talking therapy services and those VCS and community organizations might be quite useful. And the other thing that occurs to me is actually what's the link back with our social prescribers in primary care, because we sometimes assume that therapists within the services would be aware of the range of offers in the community, but our social prescribers might be much better placed if there are good relationships between our services to make those links and maybe support and signpost patients or service users to those opportunities.
Lovely. Thank you, Temi. That's been a really, really interesting question. It's raised some really interesting points. We have got a couple of hands up. I think Lucy Wilson-Shaw, did you have a question? Did you want to ask it? Come on camera and ask it for us?
Yeah, it was related to the previous question, actually. Something that we've been trialing in Westminster IAP services, a kind of direct referral route from us into the local exercise on prescription or physical activity on prescription, however it's described in your local area, which previously we hadn't been able to do. Referrals always had to go via the GP. We haven't really been doing that long enough to evaluate it yet, but we will be evaluating it and then hoping to expand it to other areas as well. But I think that's another way that you can kind of signpost people into a form of exercise or activity where someone's going to be able to kind of like sit down with them and talk to them about what's right for them and take into account any long-term conditions that they have to make sure that they're doing it safely. So yeah, I would encourage other areas to try and link in with your provider of the physical activity on referral and see if you can talk to them about a way that they'll accept referrals from you directly, rather than you having to write to the GP and saying, please consider this for this person, and rely on them to make the referral.
Brilliant. Thank you, Lucy. Patrick, were you responding to Lucy's point?
No. It's I originally wanted to respond to how physical exercise and these kind of PAs, as we call them, can help and support in alleviating weights, both at referral and in treatment weights. Of course, like any other innovative pieces of work, physical exercises or physical activities in talking therapies, it doesn't necessarily have that uptake as it would be to its full capacity, as I said in my presentation. And therefore, it could be one of the interventions that can help and alleviate weight. But also, you can be used as one of the high volume kind of treatment, because you can deliver it in groups anyway, as opposed to one-to-one. So, for example, if you had walks or dance or music or movement, sometimes we call it dance movement, and fitness therapy, that can take groups, volumes. So if you do it in a CBT or counseling one-to-one, here you can have 8 to 20, and that kind of alleviates the weight. So I just wanted to say that.
Lovely. Thank you, Patrick. Susie, were you responding to a question?
Yeah, I was just going to make people aware of the We're Undefeatable resources and campaign. So We're Undefeatable is a campaign across the Richmond group of charities, which obviously represent the charities for the major long-term conditions. And this is a campaign and support material made and created by people living with long-term conditions around empowering them to be active. It's got a fantastic website, lots of resources, but one of the things that I think is particularly helpful in the context of this conversation is the YouTube channels. And if you drop onto the YouTube channels, there is a whole plethora and suite of low impact through to medium impact exercise activities and videos that take people through and really considering the symptoms of long-term conditions. So there is that kind of support, and it's universal and free. So I think when you've got lots of people on waiting lists, it's really about exploring some of those, I think, universal offers, but also some of those local pathways. And we've already said and heard that, you know, from social prescribing through to apps, through to exercise on the referral, there are lots of pathways. So I think it is really about exploring a little bit around what's available and then matching it to what could be a sort of universal waiting list type intervention versus through into treatment. And of course, everyone will be at a different stage in their journey as well. It might not be appropriate entry point for someone to start talking about physical activity. So we recognise that. as well. So I just wanted to offer that, and I can drop the Undefeatable link in the chat now if anyone wants to check that out.
Susie, I've just popped it in, and I think Pete Dutton added it earlier in the chat as well. So that's great. Thank you. We're just going to have time for one more question. So I'm just going to go over to Johnny Loretta. Johnny, I don't know if you want to come on camera. You have your hand up. I don't know if you're there.
Hi, I'm trying to undo the. There I am. Hi. It's Loretta Johnny, but Johnny Loretta's cool as well. I use the word fat, I'll just say, to describe myself. I'm a plus size personal trainer and yoga teacher and etc. And when I went to the gym, I would go on the treadmill because I needed to get out of the house. I'd be on the treadmill, somebody would come over to me and say to me, how much weight do you want to lose? I was thinking, the weight of your opinions. Oh, I just want to get fit. No, just roughly. Oh, I don't know, okay, a stone. Oh, it's not a lot. Okay, 2, okay, 3. Then I'm on the treadmill trying to lose 3 stones when I just wanted to get out of my house and away, and just be free. So, so I decided to train as a personal trainer and a yoga teacher, done loads of courses. Everyone who comes to me is hysterical, crying, in a state. They just cannot even, I have to console them and they feel rotten about themselves. And so my thing is, a lot of, I work with shut-ins. People say they can't move. Can you get out of your bed? No, okay, I can train you in your bed. They can do yoga on the bed, use a resistance band. Like, I'll train them wherever they're at. And other trainers do it, but I'm concerned about sending people to places and the trainer's not qualified, in the sense they don't understand what they're going through. The individual can be re-traumatized. I get lots of people who've been to other people, who've been to trainers and organizations who've re-traumatized them. So and also another point was, there's lots of trainers like myself on the ground, kind of underground, almost leading little movements, who are really working hard. How do they plug into working with other people? And so I also work with older people as well. But the thing is, okay, so one more thing. So for my first class ever, that was years ago. No, it wasn't my first class. I trained many years ago before. When I put an advert for plus size class, I had a woman on a chair who could only sit on a chair. I had a man who was blind. I had somebody in a wheelchair. I had people who were really big. I had shut-ins. I couldn't believe my first class. I actually cried and I had to seek help. And I got friends who were trainers, and I trained them, and they stood next to everyone. And I spoke to the man before who was blind, and I took him through what we would be doing, and that was curvy aerobics. So I don't know what to say. There's a lot out there, and I've cried with them. I don't know what to do. I despair. That's all.
No, I completely understand where you're coming from there, Loretta. Does anybody on the panel want to respond to Loretta at all? I think we can all agree that there are lots of sort of issues and barriers and things that are stopping people from doing physical activity. I know Susie has just very helpfully put some links into the chat around the Stronger My Way resources and things as well. Sorry, Loretta, did you want to say something else?
To get to that other side, the person goes to their default mode and starts talking about weight loss and things. I'm not anti-weight loss. It's just that the language, the pressure, when they exercise with myself, they lose it. It comes off. Then I work with them, because you're going to get a lot of compliments. People are going to tell you, oh, you look good. Oh, what are you doing? It becomes another set of problems. So it's really hard. It's really difficult. So it's training trainers to not re-traumatize that person once they get there.
Thank you, Loretta. Yes, completely agree with all of your points there. Thank you. I'm just very aware of the time. We are literally into the last minute of this webinar. So I just wanted to say a big thank you to everyone who has come to this today. I know that there are lots of people still with your hands up. If you have got questions, please feel free to add them into the chat now. We are going to try and answer all the questions, and we will share them with the resources, the slides and the recording after this webinar as well. Eleanor has just put a poll quickly in the chat as well, just a little bit of feedback about the webinar, but just to say from Susie and all the speakers and everybody that has worked really hard to get this webinar together today, thank you ever so much for everyone attending. We are blown away by the number of people that have wanted to attend this today, and yeah, please feel free to send us any feedback around the webinar as well. So big thank you to everybody.